Hello, my name is Andrew Granello. I do my clinical at the Health Carpenter, which is a family practice owned by my preceptor. And the case I'm going to present to you today is a 73-year-old Caucasian male who presents with his wife with complaints of increasing shortness of breath. So my patient's history of present illness is again the shortness of breath, um, lasting 1 week. Patient notes that he has sputum production and a cough with this shortness of breath. And his wife notes to me that over the past week, he normally goes to softball, he normally works around the house, and he just feels too short of breath and gasped and able to do so. The patient's medical history includes diabetes and hypertension. The patient's medication that he takes is metformin, 500 milligrams twice a day for the diabetes, and the patient takes 100 milligrams of losartan for the blood pressure. The patient's family history includes a father who passed away of lung cancer and a mother who passed away of heart attack or myocardial infarction. The patient's social history includes that he is a smoker of the last 20 years. This is pertinent with his complaint of shortness of breath. The patient also notes that he is a construction worker for the past 30 years, which is also pertinent due to his possible exposure to asbestos. The patient states that he exercises 3 to 4 times a week playing an adult softball league, though he is unhappy that he hasn't been able to play the past week because he's been short of breath. The patient lives at home with his wife. The patient has no cats or dogs in the house, which is pertinent because maybe allergic related. The patient also notes that he is a devout Catholic and he attends Mass weekly. So the patient's review of systems, we're going to go over the fact that he complains of shortness of breath. That is pertinent. He does have a productive cough. The patient notes that he has no chest pain on exertion. He has no palpitations. This is important to rule out myocardial infarction with shortness of breath or any time of possible claudications or more of a circulatory diagnosis. We can kind of rule that out with no chest pain, no palpitations, things like this. The patient also notes that he feels a little more lethargic and down than normal through his review of systems. So during physical exam, it's mostly going to be pulmonary and cardiac base. Patient has normal S1, S2. Patient also is not tachycardic, and that he does not have any type of heart murmurs. On the pulmonary, he does have a noted expiratory wheeze in the bases of both lungs bilaterally. And then the patient on exam, when doing looking in the back of his throat, he did have some green mucus and exudates on the back of his throat. The patient did seem like he was a little short of breath, but he was not using any accessory muscles and he was not doing any labored breathing. The patient's vital signs included a heart rate of 98, blood pressure of 128/69, a temperature of 99.1. His respiratory rate was a little increased at 22 for a normal person, and then a O2 saturation of 92, which is on the low side of normal for a normal person. We would like a O2 saturation 95% or greater. The patient's height is 6'1", weight 215, and his BMI is 28.4, which is noting that he's overweight. So going through this patient, I want to make sure that we're covering our bases for my 3 main differentials at this time, which would be COPD, because the patient has a history of smoking and possible asbestos from being around construction. The patient also has similar COPD complaints such as increasing shortness of breath on exertion, a cough, productive mucus. So we did spirometry, and that did show that he has mild restrictive disease of FEV1 of 65%, which is backed up by evidence-based practice that I linked in my SOAP note, that a patient between 60 to 70% is considered a mild restrictive disease. Another possible diagnostic I'd like to use is a chest x-ray, which would further back me up. If the patient had hyperinflated lungs, that would be indication of emphysema. I also want to include now my second differential, which would be bacterial pneumonia, and the chest x-ray would be helpful here to show any opacities through the lungs would show a possible bacterial pneumonia. The third thing I'd like to include would be a CBC, which would show a more systemic infection for this patient. We're doing that because of the productive cough showing green mucus. And the last thing I would like to get is a sputum sample. If the patient does have confirmed pneumonia, the sputum sample would be helpful we may have to use a more targeted approach to his antibacterial therapy. Okay, so moving on. So I'm going to presume that this case is COPD, and we're going to treat this as a COPD case. So we're going to start the patient on medication, which, as evidence-based practice linked in my SOAP note, which shows that we need to start on a short-term inhaled therapy, which would be an albuterol, which you could use 2 puffs every 4 to 6 hours as needed for shortness of breath. The patient should also be placed on a long-term inhaler for restrictive disease. So where you're going to use Pulmicort, 1 puff in the morning, 1 puff in the evening for this patient. The last thing we could use is a steroid pack starting 40 milligrams on day 1 and 2, 30 milligrams on day 2 and 3, and then 20 milligrams on day 4 and 5, and you can discontinue. The last thing we're going to include is, if this is an exacerbation of COPD, I like the patient to start on a zithromycin pack to clean out any kind of pneumonia, which is evidenced by the productive cough and green mucus. So education needs to be given to this patient for that the rescue inhaler is only to be used in times of shortness of breath, and it is only to be used up to 4 times a day. If the patient feels like he needs to use his inhaler more than this, you should report to the emergency room immediately. The patient is also to be directed that the Pulmicort is only for long-term use. It is not a rescue inhaler, and you should only use this in the morning and evenings. About the steroid medication, he should note that with his diabetes, that his blood sugar, he can have more hyperglycemic events. Note that this is temporary, and that if he takes his blood sugar and any hyperglycemic events over 300, blood sugar over 300, he should report this to the provider immediately. So some other things that I want to do with this patient is that we need to get a clear pulmonary function test. So I want to do a stat referral to pulmonology so we can conform this pulmonary function test, so we can determine if this is a restrictive disease like a COPD and have it confirmed, which is, as evidence-based practice, is the gold standard for diagnosing COPD with a pulmonary function test. Last thing I would like to include for this patient is some of Gene Watson's curative factors, which include the promotion and acceptance of expression of positive and negative feelings. So we want to have the patient explain his negative feelings to me about the not being able to play softball, and we as a provider need to listen and need to not brush this away and sympathize with our patient. The last thing we need to do is promotion of interpersonal learning, which is all the education I gave him, empowering the patient that, hey, this is short-term, possibly short-term. We can fix this with possible interventions such as the inhaled steroid and the inhaled glucocorticoid. We can, reverse this exacerbation if it is in fact COPD. So the last thing I would like to conclude with this presentation is the follow-up. I want this patient to follow up with me immediately after the pulmonary function test is done by the pulmonologist. I would consider any recommendations for the pulmonologist on this patient's case, and that I want the patient to be advised, though, that if the rescue inhaler does not relieve any of his symptoms, he needs to report to the emergency room. This was a difficult case for us, for the provider and I, because this patient is basically on the cusp of, should we send him to the emergency room for exacerbation or should we not? And the patient was not really super excited to go to the emergency room, so we said we would do this on a trial basis and follow up with him as needed after immediately after the pulmonology appointment, as we did send in a stat referral. Thank you.